My name is Dr. Shelley Haferkamp. At the time of this recording, I'm one of the psychiatry residents at Providence Sacred Heart in Spokane, Washington. Individuals that help collaborate on this presentation include Dr. James Miller. He's also a resident here but specializing in child psychiatry, and attending physician Dr. John Wurzel, also with Providence Sacred Heart in Spokane, Washington. Today, my goal is to go over eating disorders and also how this relates to the detainment process. Very important to note is that this is in the state of Washington, so if you're listening to this presentation and you're not in the state of Washington, the detainment process may not be applicable to you, so just be really careful with that. For today's presentation, we are going to be going over a few case presentations that are loosely based on cases we have seen. We'll also go into the different classifications of eating disorders so that you're familiar with them, as well as the medical consequences of those eating disorders, how we look at capacity in the hospital, and the detainment of patients with eating disorders specific to Washington State. Our first case presentation is a 25-year-old housed male. He has a history of anxiety and dysfunctional eating behaviors. The dysfunctional eating behavior was noted as early as 2 years old when he frequently went to the pediatrician for not eating. He was also anemic and underweight through most of his childhood. There was no finding of any neurological, structural, or cognitive disorders to account for this dysfunctional eating. He always avoided meat, except just recently, over the last 2 years, has started eating chicken, fish, legumes. The only vegetables he'll eat is lettuce, which we all know is pretty void in nutrition compared to other vegetables. Fruits are hit and miss. The patient is not fearing any weight gain, does not endorse any distorted body image, just avoids foods because of unpleasant sensory characteristics, and gives example of the smell and the color disgust me. I want to vomit if I eat them. Patient went to see a new primary care doctor where it was noted that he had a low heart rate, and so an EKG was done and showed an arrhythmia. The physician recommended that the patient go to the emergency department for further workup. Unfortunately, the patient refused that option. So our patient meets criteria for avoidant restrictive food intake disorder. It's also abbreviated as RFID. If you've heard the term selective eating disorder, that was the terminology in a prior DSM version, but now it's updated to avoidant restrictive food intake disorder, or RFID. The criteria for this is that it's an eating or feeding disturbance that meets at least one or more of these four characteristics. So significant weight loss, significant nutritional deficiency. So our patient with a cardiac arrhythmia, that's attributable to this nutritional deficiency. A dependence on enteral feeding or oral nutritional supplements, and there's may or may not be a marked interference with psychosocial functioning. The disturbance is not because there's not enough food available or there's a culturally sanctioned practice in there limiting certain types of food, and the patient does not have any concern about their body weight or shape, and it's not attributable to another medical condition or not explained better by another mental disorder. Our next case presentation is about a 41-year-old housed, single, unemployed female. She has a long-standing history of extreme anorexia nervosa and social anxiety disorder. The patient started experiencing symptoms consistent with anorexia nervosa during her junior year in high school. She received a scholarship to play sports for a college out of town and actually went to college, but eventually was not able to physically compete anymore due to the fatigue and weakness from her anorexia nervosa. She did not finish college and she moved back home. Her BMI at the time that our team saw her was 15.5. She weighed 99 pounds and with a height of 5 foot 7 inches. Our team got to know her mainly because she started coming in for a chief complaint of foot pain. And so this is an example of extreme neuropathy. Her neuropathy is from a B12 vitamin deficiency that caused the nerve damage. So if you think about the patients that are diabetic who complain about pins and needles and how much that hurts, their nerve damage is from uncontrolled diabetes. So the high blood sugar is what is damaging their nerves. Whereas in our case, this patient has nerve damage from not having enough of vitamin B12. We're going to go into the medical complications on another slide later on, but for now we're just going to focus on her diagnosis. So the patient we just discussed meets the diagnostic criteria for anorexia nervosa, which is probably no surprise given that we disclosed that she has a long-standing history of anorexia nervosa. To meet the diagnostic criteria for this, you're going to have a significantly low body weight. So in the case of our last patient, she was counting her calories that she was eating, and then she was counting the calories that she burned by exercising, and she was making sure she was actually in the negatives for that. You're going to have intense fear of gaining weight. Her fear was so marked that she was running at one time up to 8 hours a day on a treadmill. The next requirement is a disturbance in the way that person is seeing their body. So our patient said during one of her therapy sessions, "I know I'm too skinny, but I like it." And there was very little recognition for the seriousness of her condition. So despite how much pain she was in, and she understood it was from her anorexia nervosa, and the discussions with the care team about how serious her condition was, she could verbalize it but not really grasp it. Next, you'll see the severity classifications: mild, moderate, severe, and extreme. And then the comorbid conditions. So our patient had a comorbid condition of social anxiety disorder, which is consistent with the known mental health disorders that frequently present with anorexia nervosa. So this next classification of an eating disorder, we're going to do it without a case presentation. In order to meet the criteria for bulimia nervosa, you're going to have an individual that is having recurrent episodes of binge eating. In order to meet the criteria, they need to be doing this at least once a week over a 3-month period. And what is binge eating? It is eating a large amount of food in a short amount of time, and that individual is going to lack control over their overeating during that episode. And then at some point, they're going to engage in the compensatory behaviors in order to prevent their weight gain. And so that might be self-induced vomiting, misusing laxatives in order to have diarrhea, other medications. They may fast, they may undergo excessive exercise. And then the self-evaluation of themselves is influenced by their body shape or weight, not liking that. And the disturbance does not occur exclusively during episodes of anorexia nervosa. Comorbid conditions are listed over here. They're very similar to anorexia nervosa, a little bit of differences, but very similar. So this next eating disorder classification, binge eating disorder, we're also going to do without a case presentation. It's unlikely that anyone within Washington State of the designated crisis response team would be involved in a patient who has this sole diagnosis of binge eating disorder, and you'll see why in a few seconds. So for diagnostic criteria, everything's going to look very much similar to the last slide. They're still having recurrent episodes of binge eating. The thing that is different is this very last bullet point, that these patients are not having the inappropriate compensatory behavior seen with the patients with bulimia nervosa. Those things like the vomiting, the diarrhea, those are what cause those acute medical presentations that we'll see. And so while binge eating disorder has medical complications, they're usually not the acute ones, which is why it's unlikely that DCR would be involved in an individual with this, but nonetheless wanted to include this for education purposes. This final classification of eating disorder is kind of a catch-all. So it's either other specified eating disorder or unspecified eating disorder. So what that means in this first category of other specified feeding or eating disorder is you might have a patient that has this impairment in functioning but doesn't quite meet the full criteria for the diagnosis that we've talked about. A good example of this is, let's say someone has bulimia nervosa, but their compensatory behavior is not at least once a week for 3 months. So let's say it's once every 2 weeks. Then they don't technically meet the criteria, but you can describe it and give the specific reason, like this one gives the example of bulimia nervosa, low frequency. The other category is unspecified feeding or eating disorder. So let's say you have someone in the emergency room. You don't get all of the information, but you highly suspect it, and they otherwise meet a lot of the criteria, but not the full criteria, and you suspect it. So you could put unspecified feeding or eating disorder. This chart is a nice summary of the 3 main eating disorders that we talked about. The first one, anorexia nervosa. These are individuals that will restrict their calories and they don't sustain a healthy body weight. Bulimia nervosa, those are patients that will binge eat and then do a compensatory behavior such as purging. Those individuals typically will have a normal body weight. Binge eating disorder are the patients who will binge eat, but they don't do a compensatory behavior, and they'll typically be overweight. I like that it gives the mean average age of onset, not that it's typically relevant for a crisis response team, but just very interesting for educational purposes. Next, we're going to focus on some consequences of undernutrition. You might see things such as hair loss and or fine hair on the skin. It's theorized that patients with anorexia grow this fine hair called lanugo during malnutrition because they don't have enough body fat to keep them warm. This is a good picture of it. It may be so marked that they're shaving it or waxing it because it's quite noticeable. Other consequences of undernutrition include swelling in the arms and legs because of poor circulation, and this is called edema. You might have mood changes because, everyone's heard the term hangry, but there's also a loss of gray matter in the brain. Serotonin and dopamine receptors are impaired, and that controls the pleasure, pain, reward. You'll have depression. You also have constipation. The reason for that is there's a weakening of the intestinal muscles, and also your body is slowing down the metabolism of your food, what little you have, because it's trying to get as much nutrition out of it as possible. You also won't have any menstrual cycles. So our patient earlier hadn't had a period in over 10 years. The reason for that is your body's trying to conserve as much energy as possible. And also there's disruptions in the hormone cycle in the hypothalamus. You also will see brittle bones called osteopenia. That's a nutritional deficiency. Also, you have an increased stress hormone during times of undernutrition, and that stress hormone is called cortisol. And that extra stress hormone leads to bone loss. You also, particularly in females, have decreased estrogen, and estrogen is a protective factor in bone loss, and in which case, if you have this disruption in the hormonal process, you're having less estrogen, and so you're going to lose that protective factor. Next, we're going to move on to more dangerous consequences of malnutrition. So you may see a low heart rate. The reason for that is the heart is a muscle, and so you're going to lose muscle mass, and so the heart's not going to work as well. Not only does it not beat as strong because it's not working as well, but the body's trying to conserve energy just like it was with the hormonal cycles. So it's going to lower the heart rate. So now you have a heart that can't pump as well, and it won't pump as fast, and then you wind up with a low blood pressure. You may also see low blood sugar. So patients can actually die of hypoglycemia. So our patient on her last hospital stay struggled with hypoglycemia. So think of someone with type 1 diabetes who's worried about low blood sugar. They have candy on them. The reason for that is because, of course, it can be fatal. You may also see low temperature. That's from that low body fat leading to that low body temperature. You typically won't see that till the final stages. So by the time you see that, you likely have all these other vital sign changes in the patient. So let's go back to our case presentation of the 41-year-old female with the long-standing history of extreme anorexia nervosa. On one of her earlier hospital stays, the psychiatry resident group was consulted. Since this time, she's had several urgent care and ER visits, some resulting in admission for concerning labs, including declining kidney function, low potassium, low magnesium, low phosphorus. What happens when you have these abnormalities in the electrolytes, it changes the way the heart beats. And this patient on the last day showed EKG changes. So the way the EKG is, you see it in the movies, and then it flatlines. So that's what the EKG is. And in these patients, when you have those electrolyte abnormalities, it can change the way the heart beats to the point that it can turn into what we call fatal arrhythmia, so it can kill them. At the time of DCR last being called on her, the patient was just discharged from the hospital. The next day, she was called because she had concerning follow-up labs, and she was directed to return to the hospital, but she refused that recommendation. So what I'd like to go through with this case is to use it to go through the detainment process in Washington State for those with eating disorders. So in order to do that, let's first start with why this patient needs to be detained for the dangerous medical complications. So I want to point out again that this DCR's information is irrelevant to the state of Washington. So if you're listening again from outside of Washington, your state might have a completely different process. So this might not be relevant to you. Back to the case. So at this time, the patient was at home, refusing to come back to the hospital. DCR was called. There's a few things she's telling DCR. So she's saying, I'm eating now. Never been this scared. I'm going to eat. I'm going to follow what they say. Then she says, I live with my parents and I can be monitored. They can even take off of work and watch me. She also says, I go to outpatient appointments and I have an intake for an outpatient behavioral health service coming up. So I'm good, you don't need to detain me. So what should a DCR person consider for a patient like this? So let's take the first thing that patient said. I'm really scared, I don't want to be hospitalized, and I don't want to die. Because of that, I'm really motivated, I'm going to eat at home. That sounds very reasonable, right? She's listened to the medical community and she says, I'm going to do it. But one thing to consider is something called refeeding syndrome. It's very important to think about. So it happens when the patient's eating something, so then now they have an increase in sugar or glucose in the body from the food they just ate. Well, the pancreas sees this and says, okay, I've got to make insulin because now we have higher sugar. Well, the insulin promotes the cells to take up the sugar, the potassium, the magnesium, and the phosphate. So now we have someone who already had low electrolytes, and then the cells are taking up more. And remember from our last slide that low electrolytes can cause the heart to beat irregularly and to the point that it can be fatal. There are different protocols for managing refeeding syndrome, but almost all of them circle around having the patient hospitalized because you've got to monitor those electrolytes. So you see all these deficiencies, the micronutrients. If you see to the right of that table, everything's heart related. So that's something to be really worried about in these patients that are saying they're going to eat now. What's interesting is refeeding syndrome was first documented in the medical literature after World War II. So there's also a research study about that time of chronically semi-starved research volunteers that described these medical consequences. And then it's also documented how refeeding syndrome likely killed thousands of individuals freed from the concentration camps. If you do a quick Google search for refeeding syndrome World War II, you'll find a lot of stories, and it'll certainly help you remember the dangers of refeeding syndrome in a patient with anorexia. So I mentioned a patient being admitted to the hospital for concerns for refeeding syndrome. Why is that important? Why can't they get labs by their doctor outpatient and have an EKG done at their doctor's office? The reason is those first few days are really critical, and you're more likely to drop your electrolytes, which leads to that fatal heartbeat. So this is an example of a 10-day management plan that a hospital doctor might use. It varies a little bit, but what I want to point out is see day 1 to 3, that third bullet point, it says measure electrolytes after 4 to 6 hours, then daily while feeding. So you're measuring this blood work every few hours and then repleting those electrolytes if you see that they're too low. If you are at home, it might be the next day or the day after that before you get results. Well, you can't replenish electrolytes based off of old labs. So it's really important they're inpatient, not only for that, but they're also on cardiac monitoring. So the beating of their heart is being monitored in live time to also catch any irregularities that way. As the days increase with the patient receiving nutrition, the risk of refeeding syndrome decreases. And so you can start decreasing the level of care the patient needs, which you'll see in this protocol. Just to wrap up for this, with a patient saying they're eating now, but they weren't previously, that is very dangerous to do at home. If you're seeing a patient who you're concerned for this, I want to encourage you to talk to the provider about it. It's really rare for a provider to see refeeding syndrome. So it wouldn't be unheard of for a doctor to not have this in their differential diagnosis. It's something they may not even be thinking of. So I want to encourage you to mention it, and you might literally save someone's life. And my hope would be that the medical staff is responsive to your concerns about the patient. So picking out something else the patient said. So she said, I live with mom and dad. They can even take some time off of work and they're going to watch me. Therefore, this is just as good. I'm set. And from the outside looking in, it looks pretty reasonable, right? She has a good family support system. She has people that's going to be there. But something to think about when you hear that. What level of support is the patient actually needing? This patient got this sick, eluding these exact same family members. Nothing has changed in her environment at home, where she has spent years with severe anorexia that's just worsening. So what level of support is really needing? Is home enough, despite that it seems reasonable? So some things to think about. How many outpatient places have declined to see this patient? Why is that? Does it mean they're not safe for outpatient? Our patient was seen outpatient by the Emily program. What that is here is a facility in Spokane, Washington that specializes in eating disorders. And they told the patient that she needed inpatient treatment and she wasn't safe to be outpatient. And so if you think about it, here's a program that specializes in eating disorders saying you cannot be outpatient safely. So, put that in your mind as saying, okay, this is someone specializing in it, despite the patient trying to say that outpatient is safe for her. The specialist in the eating disorder said it's not. Also, can the family truly monitor input and output? What about weigh-ins? What about how much she's exercising? What about some clothing? So these patients have found tricks online, some things you might think of that I would have never thought of, and same goes with family members. So reasons to get out of eating. My stomach hurts. I have a headache. They bring food to the room, well, they'll then throw it away and find a way to hide it there. They're waking up earlier than their family and saying they've already ate, they're full. They're stuffing food in a napkin or shoes or insulated bottles. They're dumping food down the garbage disposal but leaving a wrapper out to appear that they ate it. They're cutting food into tiny pieces and moving it around on their plate. They're becoming really talkative at dinner to not eat. They might be using laxatives. They're faking that food is the best part of the day and you're energetic and happy. So it doesn't look stressful that they're eating, and that drops the family's guard. Also with the weigh-ins, they're overloading with water beforehand, which can be incredibly dangerous because you lower your sodium level in your serum, in your blood, which can lead to seizures. They also sew heavy objects like batteries into their clothes, heavy objects into menstrual pads. As far as working out, our patient was running on the treadmill for up to 8 hours a day. They'll also fidget and do nonstop little movements to burn calories. What hours are the family there? Are they working during the day? Can they watch for those things? People with eating disorders, if they're severe enough, they've been usually hiding it for a long time, and they've made it this far because they're good at it. So think of all of these things when thinking about, is it realistic for the family to monitor for these things that they haven't been trained on? And this patient has been home for a while. Nothing's changed in that outpatient setting. And so should you expect it to be any different this time? So one of the other things this patient says in order to advocate that she not be detained is that she has an outpatient appointment at a facility, so it's a first appointment coming up. So what should you think about with this is that this facility's never seen this patient. No provider has looked through her record to say that she's appropriate. This is a scheduling person who made the appointment. We do have documentation regarding other outpatient facilities who've seen the patient and said the outpatient care is not an appropriate level of care. So yes, she has an appointment, but can we really count on this being the right place for her? That provider might see her and say, like all the other providers have, you cannot safely do this outpatient. So keep that in mind when you're thinking about she has a physician's appointment. Some other things is that there are no inpatient services that specialize in eating disorders in the state of Washington that accept involuntary patients. However, patients can still be admitted here to inpatient psychiatric units for treatment. Another alternative is that the patient can be transferred out of state. Keep in mind that placement of a patient shouldn't be a concern for detainment. This is just supplemental information for you. There's also a number of outpatient services which are also voluntary, but each of them have their own restrictions. So they might restrict based on insurance, age limits, BMI, medical concerns. So not necessarily that this is the easiest thing for this patient to find, but just a heads up for what's out in the community. So now we're going to change gears a little bit to talk about capacity evaluations that are done by hospital providers. This should not be something that a DCR is doing. This is just for information. However, I want to give you some background information on how it's done. When a hospital provider is determining capacity, they may ask the patient things like, do you know what's wrong with you? What are the doctors recommending? What do you want to do? What are the risks of those options? If you told me you want to live, why are you leaving AMA? These things give the physician who's trying to determine if they have capacity, does the patient understand relevant information? Can they grasp the situation and the consequences of it? Can they take their treatment options and reason them out and communicate a choice? And not just communicate a choice, but have a consistency to what they're communicating. So now DCR is called. Likely the physician or the medical provider has already decided this patient has capacity, but something's not good. I need DCR to respond to take a look at this patient. So now let's talk about these cases we've looked at. Can this patient be detained? So DCR specific law language, which is something you guys are already using in your job. So gravely disabled means a condition in which a person, as a result of a behavioral health disorder, is in danger of serious physical harm resulting from a failure to provide for his or her essential human needs of health or safety, or manifests severe deterioration in routine functioning, evidenced by repeated and escalating loss of cognitive or volitional control over his or her actions, and is not receiving such care as essential for his or her health or safety. So now let's break this down to how do you apply a patient with an eating disorder to grave disability. So look at that first piece. Gravely disabled means a condition in which a person, as a result of a behavioral health disorder. So behavioral health disorder would be their eating disorder. Part A says physical harm. So anorexia nervosa has the highest mortality rate of any psychiatric disorder due to starvation-related medical complications, which we addressed in the previous slides. So some of these patients aren't medically cleared and yet want to go home. The next part says they're a failure to provide for his or her essential human needs of health or safety. This includes nutrition, which the patient is neglecting themselves of because of their behavioral health disorder. So just based on this, we can already match how the patient could meet criteria for grave disability. So we've already made a case that we can detain the patient with the eating disorder based on Part A. But let's see, could we make a case also for Part B? So Part B reads, manifests severe deterioration in routine functioning evidenced by repeated and escalating loss of cognitive or volitional control by his or her actions, is not receiving such care as essential for his or her health or safety. So taking that apart, eating disorders are an illness that prevents volitional control. When you think of patients with psychosis, their decompensations are much more dramatic, but those with eating disorders can be a little more subtle. Maybe they are genuinely planning to eat, but they have a pattern of not being able to do this. This failed outpatient, are they poor faith? Or did they just not mean to do it in the first place? So this is that loss of volitional control, and you can take their pattern of what they've done in the past to show that they've lost control of being able to eat or not purge or eat a wide variety of food that's enough to not cause malnutrition. Their choices also are more guided by short-term outcomes than long-term outcomes, showing this cognitive piece that's limiting good choices. And of no surprise, a person with a malnourished body results in a malnourished mind, which will struggle to function optimally. There are multiple studies that you can find that discuss smaller brain volumes in patients with eating disorders, which is just more physical proof how these patients are impacted cognitively by their eating disorders. So now let's look at those cases again. Could you detain them and how would you do it? So we had that patient, the 25-year-old house male, has a history of anxiety, went to his outpatient doctor, found to have a low heart rate, EKG was done showing an arrhythmia. This is the patient that had dysfunctional eating since the age of 2. Frequent physician visits, physicians ruled out neurological, structural, congenital disorders. The patient's not fearing gaining weight, doesn't have a distorted body image, but can't tolerate certain foods because of that unpleasant sensory characteristics. Now this doctor is saying you really need to go to the ER, you can't go home. But this patient has had this for a while and says, no, I'm not going. This patient's not medically cleared, right? That makes it a bit easier for detainment. Why this patient meets Part A of grave disability? Because of being in danger of serious physical harm, because they're not providing for their essential needs, which is nutrition. So let's check this one as being able to detain, and let's see what the next one looks like. So this next case in presentation, it's a 30-year-old female. She has a history of bulimia. She's admitted to the hospital because she has low potassium. And she says, fine, I'll be admitted. And as soon as she gets there, she says, nope, I want to leave now. So take a second. How will you apply this one, right? I'm going to give you a minute if you want to pause it. All right, and then this is really similar to the last one, right? This person's not medically cleared. they are admitted for a medical complication directly related to her bulimia. Now she wants to leave. So she needs Part A of grave disability because she's in danger of serious physical harm because of not providing for essential human needs, which is nutrition. So that one's very similar to the last one. So let's go back to this case presentation that we've used a few times, the 41-year-old with severe anorexia nervosa. So let's say she goes home, she follows up outpatient with her doctor. The outpatient family medicine doctor has nothing medically to admit her. The electrolytes on the last blood check are normal and EKG isn't concerning, but the doctor is worried she will die and calls DCR. What do? So you're seeing this patient at home with their family saying they're fine to be home, and no one wants this patient to be in the hospital for psychiatric or medical reasons. They're really pushing back on you. How can we apply the law here? So the physician called because they believe the patient's in danger of serious physical harm, in this case death, because she isn't providing for her essential human needs, which is nutrition. So do you see the similarities, how you've already met Part A, but wait, hold on, the family says they can watch her and she'll eat, but what about refeeding syndrome? We know this isn't safe for the patient to all of a sudden start eating at home. She needs to be medically monitored for those first few days. Not to mention, we've already mentioned the concerns about her outpatient setting has not changed, yet she's staying in the same environment. Nothing's changing for her. She still has that same pattern of failure at home. Now, can she meet Part B? So you find out that the patient has had this condition for years despite outpatient treatment. We could make a case that she has a loss for volitional control with those past failed attempts. The family members have been there for years. The outpatient setting is not going to change that, which the patient has already failed at. So regardless if we change this case and said she's in the emergency room, she's on the medical floor, she's at a friend's house, she's in a homeless shelter, we really come up with the same conclusion that she's detainable, just like the other cases. DCR, you all see psychotic patients or patients with SI often. Seeing patients with eating disorders is less common, but you can see how you apply the same law you're already using and the same logic as you do with other patients. It's just a different patient population that you're already seeing. All right, so thanks for listening in. I hope this has been helpful for you. If you found something in this PowerPoint that you think, I disagree with that, or I think this should be added or elaborated on, let us know. We're happy to edit things if we can. We're open to your feedback, and thank you again.